Hello everyone, my name is Ollie. I'm a junior doctor living and working in the northeast of England as part of the NHS. Welcome back to my YouTube channel. Now apologies because there's been a lot of these, but this is one of those keeping you up to speed on the weird and wonderful news that's going on in medicine. And this one is really important for anyone who wants to be a surgeon. So maybe you're thinking about applying to med school, you're in med school, or you're a junior doctor wanting to become a surgeon and enter surgical training in the UK. This video is for you. Specifically today we're talking about core surgical training. There have been some really major changes to the selection process that I think everybody needs to know about because your medical school aren't going to tell you. So firstly, we need to address what is core surgical training. That's a really good question. Core surgical training, the simplest way to think about it is the stage of surgical training that takes place after you've finished your foundation training. So you do your med school, F1, F2, then you enter this process called core surgical training, which lasts for 2 years. And after completing that, you would go on and apply for a job as a surgical registrar in the specialty that you want to work in. So core surgical training is this bit in the middle where you do F1, F2, core surgical training 1, CT1, core surgical training 2, CT2, and then ST3 is where you become dedicated to your single specialty that you're going to train in, whether that is orthopedics, plastic surgery, general surgery, any of the specialties that recruit to higher training via core surgical training or CST. And that's an important distinction to make because not all surgical specialties recruit this way. There are a small number of more niche specialties that don't use core surgical training and instead utilize what's called run-through training, where they go in ST1, which is straight after the foundation program. And examples of those include cardiothoracics, neurosurgery, and ophthalmology are all good examples. So if you're a medical student watching this, I would stop the video here. If you're thinking about surgery, go and Google whether or not the specialties that you're interested in recruit via CST, core surgical training, in which case this affects you, or they're done as run-through, in which case this video doesn't affect you. Come back and we'll carry on. The second thing we need to understand as the preface here is that surgical training is extremely competitive. Lots of people want to be surgeons, far more people want to be surgeons than there are surgical training posts, and this creates competition. Competition then in turn drives applicants to try and be better than the person next to them so that they've got more of a chance of getting a job. And obviously this leads to a cycle where every year the average candidate gets better and better and better and better and more competitive, and it becomes increasingly difficult to actually separate them from one another and pick them apart because everyone is so good. And this is an age-old problem that is nothing new to us in medicine, right? We've all been through this process as far back as applying for medical school. You've got to try and select from a load of 17, 18-year-olds who all have 3A grades, were all head boy, head girl, whatever, were all captain of the cricket team, all had their gold D.A.V. award and all played clarinet or something to grade 8. You have a mostly homogenous, similarly qualified, very talented group of people. And what happens is the people who have to make these decisions set the goalposts in a particular place, whether that is grades, volunteering experience, whatever. Naturally, your very intelligent, able and motivated candidates will do everything they can to hit those goalposts, and the overwhelming majority will achieve those goalposts. So you've then got this same problem. How do you pick people apart? And this is the eternal question to which nobody has a good answer. And with that out of the way, this brings us back to thinking about core surgical training, why it's changing and how it's changing. And this next section of the video draws from a document released by the JCST, which will be linked at the top of the description, and that's what we're going to talk about now. So the long and short of it, and the big major change, is that core surgical training has adopted what's called the MSRA, the Multi-Specialty Recruitment Assessment, which is an exam. It was an exam that was first introduced to select GP trainees, that is early careers doctors who are going to embark on GP training, become a GP registrar, and ultimately become a qualified GP. And not only is it being introduced for this application cycle, 2022 for 2023 entry, entry, it's also, as far as we know, the only way that people are going to be shortlisted and selected to get to interview stage. What that practically means is that your portfolio, this being things like your MRCS exam, your courses, your publications, presentations, prizes, this thing that people have spent years and years and years working on, means nothing in terms of getting you to interview. It's all about this new exam. Now, it's important to note that the portfolio isn't completely gone. The JCST have clarified this, and it will still count for 30% of your total score when it comes to assigning candidates to training posts, but that's only post-interview. And they've said that it will count for 30% of this total score. Forgive me for reading, but the big changes here are the MRCS Part A, so that's the membership of the Royal College of Surgeons exam, is no longer included in the portfolio. Points for courses such as BSS, Basic Surgical Skills, have been removed, as well as points for prizes and additional degrees. The portfolio segment will now only score points for commitment to surgery, which is a carryover from the previous person spec, quality improvement and clinical audit, again, this is nothing new, presentations and publications have stayed in, and teaching experience and training in teaching, which are also carryovers. So effectively what's happened is the portfolio has been slimmed down in terms of the things that it scores points for. Now, they haven't made clear as of yet how exactly the points are going to be divided and broken down here, or what exactly will score points under these domains. But to repeat myself, what they have said is that the portfolio will count for 30%, about a third of the total score. The MSRA, that entrance exam that's shortlisting you to interview, will count for 10% of the total score, and the remaining 60%, the overwhelming majority, comes from the interview itself. So once you get shortlisted for interview, it's actually overwhelmingly about your interview performance. So for medical students and junior doctors, what do these changes mean on a more practical level? It means that there is perhaps less pressure to get your MRCS Part A early, which at the moment is a very common thing to do in your F1 and F2, as it won't be actually tangibly worth anything until ST3, by which point you're required to have both your Part A and Part B anyway. Now, an important thing to reflect on is that pass rates for the MRCS Part A are actually highest in F1, that is closest to medical school, and the pass rates for Part B are highest in CT1. Extra degrees for those of us that did graduate entry medicine, or perhaps those people that are intercalating, are now worth 0 points at the foundation program level, so your first job as a doctor. They're not worth anything outside of the specialised or academic foundation program, and they will now not be worth anything at CT1 level either. Again, just with the exam of perhaps delaying the value until ST3. Again, less pressure for paying for courses now, like Basic Surgical Skills, because again, shunted to ST3, and the same with prizes. You've perhaps got a little bit more time to get a portfolio together. Functionally, this means that your efforts are therefore probably better spent on these domains that have stayed in the portfolio. If you want to do surgery, that is your audit and quality improvement, presentations and publications, the same as before, and teaching experience and training in teaching. Commitment to surgery is a bit more nebulous, but I can only assume this is going to be things like surgically themed electives, student-selected component modules, and taster weeks as a junior doctor. So now into the final segment of this video. What are my thoughts on this? I'm really keen to hear what you think. It's a really strange time, lots of things being announced all at once, so let me know what you think about this down in the comments. But hands up before I get shot. I think that the ethos of some of these changes, or that is the principles behind them, are actually quite a good thing. Given that things like courses and the MRCS are incredibly expensive and time-consuming to deal with, and we don't get any protected time or funding for these things as an F1 and an F2, I think that actually removing them from selection is not necessarily a bad thing, at least if you accept that funding for these things won't be available. To a degree, courses with things like Basic Surgical Skills costs nearly £700 for the 2-day course. It's basically pay to win at that point. All you're really selecting for is the people that can afford to pay for the course. And indeed, there are free courses like the National Catheter Education Programme that are free and worth exactly the same as a £700 surgical course. The entire points market, therefore, is a weird proposition and not something that I think we should continue to engage with. But there are two big major issues with this change for me. The first thing is the timing. This is a really obvious one, and the JCST have introduced these changes mere weeks before the application deadline. That means that it's effectively impossible to modify anything about your situation before you are locked in by the entry deadline. You can't introduce any new evidence after your portfolio is submitted. And this is unfortunately nothing new. This happens every year across at least one specialty, where people will spend years tailoring and crafting their portfolios. It's really reasonable to think that someone perhaps in their third or fourth year of medical school wanted to become a surgeon. They then did all the correct things that they were supposed to do, putting hours of time, effort, hundreds of pounds of money into making the portfolio that they were told was going to help get them a surgical job. And then at the very last moment, the rug is pulled, the rules are completely changed, with not enough time to actually change anything about the situation. It's very easy to imagine that that same erstwhile, hard-working, motivated young medical student or doctor, had they known that the rules were going to be different, would have put their efforts into something else, into the domains that would have scored them the points. The sheer number of hours and the effort that it takes to prepare for the MRCSA by itself, this is a process that I'm going through at the moment, would be just as easily spent, getting an extra cycle or loop of an audit done, or working on another project to publish, or going after prizes. You can only spend your effort in so many places, and we rely on the colleges and the people making these decisions to tell us where that effort needs to go. Now, at the very last second, they've pulled a bait and switch and said, oh, actually, anyone who spent all that time revising for the MRCS, whoops, you should have been doing all of these other things, idiot. It's ludicrous. It's an absolutely ludicrous and callous situation. And the second big major issue for me is the use of the MSRA itself. There is some real weirdness going on here. As I've said before, the MSRA is a GP exam. That's what it's validated to do. That was what it was designed to select for. And there is nothing new about the MSRA being used to select for non-GP specialties either. Radiology, anaesthetics, neurosurgery all use the MSRA. That's kind of not the issue. But the issue here with this particular scenario is the way they've gone about getting their evidence base. And again, I'm going to have to look back at my phone just because it's so nonsensical that I can't retain it. But what they have done here is they have looked at candidates from previous specialty application cycles who applied for both core surgical training, CST, and another ST1 level program in the same application cycle. So that might be something like radiology, anaesthetics, GP, whatever. Basically, they've applied both for CST and for another specialty that already uses the MSRA. So even though their MSRA score wasn't being used in the context of their CST application previously, it was being used for assessment somewhere else. And that is the data that they've pulled across. And what they've shown basically is that there was a significant difference in MSRA scores between those that were invited to CST interview and those that weren't, purely based on that small group of scores. And because of that, they've posited that it's non-inferior to the current system that we use, which is based much more heavily on portfolio scores. What you've got here is a cohort that weren't all in on surgery. The only cohort that they can see is the people that applied for both core surgical training and at least one other specialty that uses the MSRA. They haven't told us which specialties those are. So, for example, you could have someone that applied for CST and for GP. It could be that you had someone that applied for CST and for neurosurgery, or CST and radiology, and any combination of these things. But what you're missing here is the cohort that only applied for CST and would rather take a year out and then apply again next year rather than not be a surgeon, which to me is going to make up, if not the majority, a hugely significant proportion of your applicants. And my prediction, I'm putting this on video now, on paper now, so hold me to it, is that once you reintroduce this cohort back into the selection pool that only want to do surgery, that will inflate MSRA scores because these people only want to do that. You've now put another goalpost in the way that says you have to do the MSRA, and your score is the gatekeeper to you becoming a surgeon. They are going to work flat out and do nothing else but revise for this exam in the time they've got between now and January. So that's 3 months, whatever. What then will happen the next cycle is that because we will now all see this coming, we know that the MSRA is the only thing used for shortlisting. You're going to have F1s revising for the entire year for the MSRA beforehand, which will again inflate scores to the point where they become kind of meaningless. And you're going to get this same clustering problem where people become increasingly difficult to pick apart at the top end. So God knows what that does to the predictive validity that they're trying to postulate here. I think the effect that they've got this cycle, because they've pulled the rug and introduced this thing at the last minute as a selection tool, the validity that that gives you is going to be so different to the validity of the same tool in a year, in 2 years. It's going to be a cycling problem that will get worse, especially as more and more and more medical graduates come through and there are fewer training places. So ultimately, to close things out, what do we have here? We basically have a situation where there are too many people who want to be surgeons for the number of training places that there are. They needed a blunt tool to simply cut down the number of people that they needed to interview, and they have opted to use the MSRA for that tool. They have then kind of decided to try and polish the turd a little bit with some nonsense evidence that just happens to look roughly correct, but we all know isn't. They've just kind of enforced it and said, this is what's going on now. No appeal, no nothing. We've made up our minds. With no regard for any of the trainees or the students or the huge number of people this affects. And this is medicine. Everyone looking on, if you're thinking about going to medical school or if you're in medical school, like, this is how it is. This happens every single year. There is no workforce planning, no nothing. It's all just short-termism, what will get us through to the next cycle with just no regard for anyone involved. And, you know, this is the state of things. So I hope that's been informative. Let me know what you think. Take care, and I'll see you soon.